Yeah, thank you, Sophie, and welcome everyone. I hope you're ready for really enlightening discussions. We have some great experts here at the table that have done the identity management deployments, and we're certainly interested in hearing your questions as well as we go along. I'm Rosa Caputo. I'm CEO and founder of KeyData Associates. And for those of you who don't know KeyData, we're an identity management services company. We're based in Canada, but we also operate in the US with a head office in Boston. And we deliver identity management services that include assessments, deployments, as well as managed services to clients across North America. Happy to be here, and I'll just pass it on to Scott to introduce himself from Sick Children's Hospital.
Thank you, Rosa, and good afternoon to everybody on the call. My name is Scott Currie. I'm the Chief Information Security Officer for SickKids as well as for the University Health Network, UHN. So very pleased to be joining this panel today. We've been on a journey towards the implementation of identity management for a number of years now, and while it's never something that you can fully complete, I think we've made an awful lot of progress, and I look forward to being able to share a little bit about how we went about it, some of the lessons learned with this group. So thank you.
Okay, I'll just pass it over to Andrew from New York City Hospitals and Healthcare.
Thank you, Rosa. And yes, I've been with New York City Health and Hospitals for about 12 years now on my journey on getting an IDM application up and running and servicing our community. And look forward to answer any questions, going through our presentation.
That's great. Thank you, Andrew. And now I'll pass it on to Matt Radcliffe. And I just want to introduce Matt as our co-host. Matt is with SailPoint, and we're delighted that he's able to co-host this event with us. Matt?
Thank you, Rosa. So hi, everyone. Good afternoon. Matthew Radcliffe. I'm the Area Vice President for the Healthcare Business here at SailPoint. I've had the pleasure of collaborating with our healthcare customers over the last 10 years at SailPoint, and I've been in the identity security space specifically with a focus on healthcare over the last 25 years. So really appreciate Andrew and Scott and Rosa for taking the time to do this today, and look forward to speaking with everyone.
Thank you, Matt. So we don't have any formal presentations, but we're going to have interactive discussion, and we welcome questions as we go along. So what we're going to do is we'll ask questions of our speakers and our panelists, and they'll jump in and try and answer the questions. So we'll start with the first one, which is, I think, a question that is near and dear to most people as they get started on an identity and access management program. How do you convince the C-suite that investing in cybersecurity programs such as identity and access management are worthwhile? And how are you able to secure the funding? Do you have any lessons learned from this experience? Feel free to jump in.
Yeah, maybe I'll step on that briefly. I think for us the convincing was, frankly, not that difficult. I think when you look at the space in cybersecurity these days, there's a number of clear and obvious risks that organizations need to address. And at the time when we were making our decision about how to proceed with implementing an identity solution, we were in parallel preparing to launch our new health information system, which is EPIC. Many of the folks on the call will certainly understand the enormity of that effort. But what we quickly realized as we were beginning that EPIC project is we fundamentally did not have a cohesive set of processes to allow us to manage user access. And given the size and complexity and the broad nature of what's required in order to be able to effectively use EPIC, a set of decentralized processes based on incomplete and scattered data about our employees was never going to be an effective model to be able to manage this. And so we had conversations very early about, what access management for Epic could look like and how we could then potentially take that access management model and begin to extend it more broadly in the organization. And certainly we talked about that in the context of risks. Obviously, when you're thinking about health information, privacy is one that comes to mind, and we have a series of obligations around audits and management of privacy. So making sure that we had a cohesive set of centralized processes that we could attempt to automate over time to be able to build in checks and balances to validate that certain prerequisites for access were in place. All of this became a very compelling discussion as we started thinking about how we were going to invest in this. When you think about the amount of manpower necessary to run a decentralized set of manual processes across an organization the size and complexity of SickKids, we were very quickly able to demonstrate that, having something like this not only allows us to create these operational efficiencies, create greater visibility into what's happening both within Epic as well as in a number of other systems, both connected and disconnected from Epic. And the cohesiveness of that vision really became quite compelling for us. And so we very, quickly were able to get approval to move forward with understanding, what an IAM journey could look like for us. And, we're now 3.5 years into our Epic implementation, and certainly by no means are we done. But we've seen an awful lot of really significant improvements in the way that we're able to manage our users over time. The ability for us to more quickly turn around access as part of the onboarding, which historically could take many, many weeks in some cases. So the speed of being able to be responsive to the needs of the business, the ability for us to create that centralized visibility, all of this became something that we were able to put forward and achieve the kind of funding necessary to be able to move this project forward.
Right.
Yeah. So just to put on to that, our journey started in 2010, and it wasn't to justify a ROI, it was to consolidate. We had multiple identity products, an in-house version, another bought version, and none of them were serving the purpose. And we also it wasn't being used throughout the organization. New York City Health and Hospitals has 11 different acute care facilities, 6 post-acute care, diagnostic centers, and over 70 clinics that have to be managed. And each one of those had a different way of processing, just like you said, Scott. There was multiple different ways of doing things, and we needed to consolidate to one. The first thing we had to do was consolidate to one IDM. And that was to justify that was just to justify the fact that, just like you said, Scott, could take days to provision a person. And we needed to do it within hours. And we've started that journey. Then we consolidated into a single IDM in 2016 to start that process. And just like Scott said, we have Epic also. And we had 3 EMRs, but Epic, of course, being the largest. And we use one copy of Epic, but it's it's available to all our facilities now. So it was more of justification of centralizing that and getting down to one process instead of 11.
That's quite a broad scope of EHR systems. I'm sure you had a lot of complexity there to deal with, and we'll hear more about that as we go along. But so where did you start, Andrew, with all this complexity? How did you get started, and what approach did you use? Because it's like there's so much that you can do. How do you get started?
Well, the thing that I always look at is you have to start with one or the other. Either you start with life cycle management or you start with governance. I started with life cycle management. And like I said, there were 11 processes. And what we did in the first iteration of our IDM, we made it a manual entry process into our IDM so that people saw the amount of effort that needed to be done for that onboarding. So they were actually doing 2 onboardings, one into their HR system and one into our IDM. And we took each one of those 11 and collapsed them into one process for every one of the hospital systems to use. Then the second part of that process was to automate that so they didn't have to do it anymore, which of course they loved because they didn't have to do extra work. And that took things from entries by manual entries to doing things by several hours, once every 3 hours.
So how difficult was it to consolidate those processes across the various entities that you have, and how did you get the buy-in to that?
It is, so from the first part, we had to consolidate from 11 different domains. If everybody understands network domains, we had to consolidate from 11 domains to one. That was a separate project, but it was in continuum with this because we didn't want any duplicate users. So that was going on from 2011, and I didn't say it didn't take a little while. It went to about 2017 to get rid of all the extra stuff and to bring around systems that had to be consolidated also. What we did was we identified a single source or authoritative source, as you probably understand. That will be our contributor to our ADM. This took a lot of meetings, let's say selling. It was selling the idea to each one of the 11 different HR groups that this was a good process. So you had to get them their buy-in, and it took a couple of years. And that's why we did it network by network. So one hospital system by one hospital system. And then the word got around, I can do this with this. Oh, that's a lot easier. Let me go and bring that into the fold until we were doing one centralized process. And
Rosa, maybe just a really critical point that Andrew's making here that is subtle, but really will dictate the ability to be successful in an identity journey. And that's the willingness to do some business process transformation, right? Too many times, I've seen organizations want to take an identity product and literally engineer it around all their business processes, whether they make good business sense or not, highlighting their willingness as an organization to take a step back and look how they're doing things today and look for opportunity for improvement. That put them on a path to really be successful. Right? So that desire to go through that business transformation is a key element of having a successful identity program.
Well said, Matt.
I would definitely sort of maybe expand on that. I think I agree with the criticality of that, and you know, relative to Andrew's journey, we were a little bit I guess quicker to get off the ground, as it were, because we had the opportunity with Epic coming in. We did not have established processes to be able to manage users in Epic, so we were able to, as part of that go live, be able to engineer that business process that made sense for the way we wanted to operate Epic, be able to create that in a centralized way, map all of the dependencies necessary, and then be able to leverage the capabilities of software and other tools to be able to then get that into production. You know, we began, a little bit before our Epic go live with sort of the automation of what we call birthright access. So your standard, domain account, email account, learning management system account. Those are relatively straightforward. And then we built a set of processes that were mapped against our business users to understand how they needed to interact with an onboarding tool in order to be able to generate a request to say, a physician needs access to a certain module, to a certain set of capabilities. And so we were able to time those very well so that as we went live with Epic, we went live with our new identity management process that simply became the only way that people knew how to do it. And very quickly, as that was the first system we did, we started to see the effectiveness of those centralized processes, and we started saying, well, how about we bring in the next system and the next system and the next system, and automating some of those by being able to say, well, if you have this role in Epic, you're going to automatically get access to this particular clinical application, whether it's pharmacy, diagnostic imaging, et cetera. And so mapping that, we were able to say, now you request an Epic role, you get an Epic role, but it also provisions a number of other systems for you so that you're able to have that access so much more quickly. And that's really been a boon for us because it's really allowed us to get that centralized control and visibility, getting automation over the onboarding and offboarding of those kind of core authentication credentials, and be able to create great visibility into who has what access within our clinical systems.
That's great. Well, we'll move along to the next question. So how did you integrate your identity system with your electronic health care systems? And I know, Andrew, you had multiple of those, so I would be interested to hear that. And what is the best way to control the access to the EHR systems?
Well, for us, we integrate with the EMP record of Epic. The service record is still done in a manual method, more because the security people want that emphasis, and it's tied to Active Directory. So we build out the standard templates for the EMP, and it goes through the normal life cycle. So if you look at this from an Epic standpoint, when you onboard, we create your Epic record. When you change positions, we change that Epic EMP record. And of course, when you decide to move on to better passengers, we terminate that usage. And that's all done through AD, so there's nothing to be done on the Epic side. And we also terminate the record in Epic. So we disable the record in Epic. We never delete. We want the history, so we just disable it. We also have another EMR system, which is known as point-click care for our long-term, post-acute care, long-term care facilities. That is a cloud application. So we are basically pushing a records out to that service through REST APIs, through our IDM system. And the same thing, it's LCM. When they come on board, we add, because we know they're in their specific type of person role in that facility, they're going to get this record, but only those people. And then we follow their life cycle. The third EMR that we have, which is for our correctional health services, because we also manage correctional health at the city of New York, they're all manual. They haven't gone to try to integrate that. Such a small set of people. It's less than 1,500. I know that might sound for some organizations a little larger, but we manage on average 70,000 people. So.
Wow. Scott, what about at SickKids? I know you've got it up there.
Yeah, it's our journey towards automation has really been achieved through several phases. As we went live initially with Epic, we did have some core pieces of automation, and our Epic architecture is a little bit unique in that we actually share our instance with a sister hospital, but an unaffiliated hospital in Ottawa, the Children's Hospital of Eastern Ontario, and so our infrastructure for Epic is separate in its own complete separate domain, separate physical and separate logical instance, and sort of managed by SickKids, but on behalf of both hospitals. So the automation that we looked at initially was how do we make sure we get that SickKids side birthright access in place, but then also how do we automate the creation of a user object for both CHIO and SickKids into this centralized domain that's being used for authentication. And so, that automation allowed us to very quickly get that foundational component of, the ability to authenticate into Epic in place. And in parallel to that, on the SickKids side, we also created integrations into our learning management system, as well as our physician credentialing system, so that as and when people were onboarded, we created a series of validations that if an Epic role is required, we determined, first and foremost, is this a credentialed physician in the case of physicians? Slightly different for NPs and nurses and other clinical users. But for physicians, have they been credentialed by a medical affairs division? Have they taken the training modules that are associated with the role that's being requested? But we did not initially actually automate the creation or assignment of any of the templates into Epic. So our process began where we created those fundamental birthright access, and then we had the administrators for the individual departments effectively request the role that they desired for somebody that was coming on, and that role request would then trigger some workflow, validate automatically those prerequisites, and then create an item for our security team to work on to create the EMP record, assign the appropriate templates. We've since then expanded that over time, where now, as I said earlier, what we've been able to do is map other clinical systems to that Epic role. So the next phase for us was that as the department administrator selects a role for a new user, they would get the Epic role through that process that we had, which is still semi-manual, but we would also automatically provision access to our pharmacy dispensaries, for example. So the nurses and clinicians can get medication. We would provision access to certain imaging systems, provision access to certain other data archives to be able to pull in legacy history. And so that automation allowed us then to ensure that rather than requesting individually access to 4 or 5 different systems, you only request access to Epic, and then we take care of the rest of it behind the scenes. And then what we've done as our third phase now is automate the provisioning of the user, or the EMP record, into Epic. So that's now generated as part of an automated workflow. And then we still have some manual oversight around the assignment of the templates, which is sort of the next phase that we're going to start looking at. So we've really looked at it as an opportunity to improve upon and build upon the automation necessary for us to be able to get to the point we want to be. I would say, quite frankly, on the side where we've had challenges, the challenges that we face with the automation of this type of provisioning really is not having to do with our workflows. It fundamentally has to do with what I consider the biggest challenge in managing identity, which is your underlying data about the people that are within your organization. And similar to Andrew's description, we didn't have 11 different identity sources. I think we have 7, of which 3 of them are large and critical identity sources. And in most of those cases, that data is largely, unmanaged. It's sort of free-form text entries. It's, not under centralized control. And so, we have an issue being able to say, I can rely upon the data about the user in order to make an automatic business decision. So we've had to layer a degree of manual oversight into our processes, as in parallel, we work through the exercise around how do we take this really incomplete, in some cases inaccurate data, consolidate that into a single data source that we can then manage more centrally, and then ultimately be able to leverage that better data to make some of the business decisions on an automated fashion. Like if I have a physician, that physician has been hired to work in the ED, we just simply assign everything that's associated with that business role based upon the data coming from our authoritative sources. That's the piece we don't have yet, and that's some parallel work that's happening as we build out our identity system, so that when we get to the point where everything's where I need it to be, then we can do that final phase of bringing it all together to start to truly automate some of these workflows.
Yeah, so Rosa, just two points to highlight here. First, Scott, I was super happy to hear you describe the parallel processes with credentialing and learning management. These are actually opportunities to create partnerships with the credentialing team, the learning management team, to help sell the value of this internally. Two, for those that are evaluating identity in healthcare, I can tell you that the trend is typically they go to the roles within their clinical system. So for example, you might have 4,000 templates defined. The last thing you want to do is go and create an identity role model based on 4,000 templates, just because that's what you have in your clinical. When you're thinking about that role model, obviously the core clinical is most important, but you really have to think about and consider the entire application library that you want to manage identity across, and try to find that smallest number of roles that's manageable, but helps you achieve the strongest level of automation across the entire application portfolio. The last thing we want to do is marry 4,000 templates to 4,000 roles. That creates a hard environment to manage. So be very thoughtful about that. Take your time in defining those roles and think about the entire enterprise.
Yeah, and that's the approach we did take, is we knew going into our Epic build that, we had many templates, but realistically there weren't that many roles. And, while we still have a lot of roles, we did that mapping initially to say, a role might be physician or NP or, lab tech or, whatever the role might be. And for each of those roles, basically said, well, here's the set of templates that supports that role. So when an administrator requests access to Epic for a new hire, they're not asking for the 7 templates that are necessary for that person to do their job. They're selecting from a discrete list of roles that are mapped to the work that that person is doing. And then that role mapping sort of feeds into our workflow to say, well, based on this role, here's the group of templates that need to get assigned. So we don't put that burden on the requester to determine the minutia of the access necessary within Epic, because it's very complicated, as you say. The number of templates, the different sub templates that may be associated with different variables associated with different types of role, whether they're in one unit or another unit. We take that away from them. We sort of obscure some of that minutia into a sort of a business role definition, where we then map that underlying access to try and create something that's a little bit more usable for our end users.
Yeah, and I want to cue off one thing you said, Scott, where you said you had 4 different authoritative sources and they weren't all structured. We had a similar thing, but in another parallel effort from 2015 to 2019, we consolidated everything into our HR system, which was, again, selling to HR that we do want contractors, we do want affiliates, we do want volunteers inside the HR system, so that we're pulling from one source and then we can terminate from one source.
Yeah, and we're taking a very similar approach and looking to try and move those sort of external authoritative data sets into PeopleSoft. We've been very fortunate that HR has been a very strong partner and a very strong advocate for these processes with us throughout our journey. So the issue for us has not been convincing HR that our authoritative source should include these other user types. The issue for us is figuring out who's actually going to do the work to go through the data, fill in the gaps, migrate that data, map it all together to kind of create the data set that we need. We've gotten to the point where, we have a fairly well-defined data model that we think is the right data model that incorporates all of the different needs and use cases from different clinical areas from our research team. But the work to take a data model and then fill in all the underlying data that has decades of misuse in it is a significant challenge and a significant undertaking. So we have the alignment. What we have is the challenge of being able to actually do the work necessary to move that data in a way that it becomes usable. And that's the piece that we're working on right now is how do we start to build that work plan, and how do we start to resource that work plan in order to be able to get to the point where we can deliver on the promise of a unified data set for all of our users.
Yes, absolutely. It is a really critical element of a successful deployment. Where is the data, and what is the quality of that data, and how do you clean up the data? I guess, Scott, as we went through it at SickKids, it's a real showstopper. If your data quality isn't there, you can't really automate your process, can you? Because
no.
The source of data, and I think it's probably consistent across many hospitals in Canada, and I'm sure in the US as well, that if you haven't got that single authoritative data repository, you got to figure out where is that data, and when you bring it all together, does it line up? Is it the same person here that is defined with these attributes as over there with these additional attributes? And trying to consolidate that is quite an undertaking, isn't it?
Yep. But it is key. It really is the fundamental barrier to being able to extract the value out of these processes that you can. And that's not to suggest that there isn't value in starting without that clean data. And that's sort of the lesson we've learned is, we've been able to deliver on a lot of what we wanted to do. We've been able to create these centralized processes, create some automation, being able to map those dependencies and build out a set of business roles. So we've actually made, a significant amount of progress from where the organization was 3.5 years ago with respect to how user access was managed. But given the luxury of time, having a clean data set before you start certainly gives you a leg up in being able to move much more quickly to deliver on the promise of automation. But that data question is a hard one. It's, there's an awful lot of legacy that needs to be overcome in healthcare systems where, the old applications, different ways of authenticating, decentralized, databases of user credentials, all of this becomes very, very difficult. If the luxury of time is there, you might look at cleaning the data and then layering on your processes on top. But the reality is sometimes you don't have that luxury of time, and simply being able to centralize a process to be able to define some very core, components of automation, has allowed us to move very, very quickly in being able to achieve what I think is a fairly well-controlled set of access models, automated onboarding of certain things. More critically for me is the automated offboarding of our users, because that's sort of a historical pain point in a lot of healthcare is, people leave, but they still have a badge, they still have Active Directory, they still have emails because, nobody got notified. So the fact that we're able to do a lot of these things, at that birthright level gives me a lot more confidence to be able to say that, access to my critical applications, even if we don't have full automation, I have the ability to ensure that some of those key components of authentication and to some degree authorization are being handled through some very well-defined centralized processes.
Yeah, excellent. Like one key question I think worthwhile when it comes to offboarding, worthwhile asking to see if you have a problem is how many active badges do you have in your system? And how many users do you have in your system?
Well, when we started our process, Rosa, and you may recall, we have something around at any given time 12,000 active users between corporate staff, physicians, volunteers, different clinical users, researchers, etc. And we looked into our badging system, and I think we had 48,000 active badges. So, that it is a pretty good indicator of where you might be in terms of your offboarding process.
It makes the whole program worthwhile. And going back to the point you made about the data model, the data itself, there is a lot of benefits to the organization besides just the identity management program to have clean data for management decision making. Who are these people? How many do we have? In what role? And if you can't answer basic questions like that, it's not just your identity program that is going to suffer, but the organization as a whole, in just overall execution and effectiveness. So so it ties back to the business case and the value that the identity program brings in, all of the prerequisites to having a successful deployment and the efforts that need to be undertaken benefit other parts of the company, as well as just being able to smoothen out the identity program. Andrew, did you want to add to that? I wasn't sure.
Basically, Scott went through most of it.
Okay.
The key in our data model again was cleaning it, and it was cleaning. We because of our 11 different domains at one point, we had a Andrew Greenspan in 3 different domains, and it doesn't really work very well when you're trying to authenticate. But then again, we had 7 different EMRs, versions of a same EMR. We had 7 versions of Quadramed, if anybody, or QCPR, each one for each one of the regions, and they didn't talk. Thus, the need for an Epic in one instance, and then cleaning up all those users. So yeah, the data model is critical. We added several attributes to our AD just to control everything.
Yeah, for sure. I think there a question came in on Epic, Matthew.
It did. Let's see. Were you able to fully provision? So Scott or Andrew, you can jump in here, but let me give a little bit of edification around the Epic integration. So the question is about fully provisioning Epic EMP and SCR. Just for edification, because it's important as you plan your program. Historically, Epic's API said, and I do strongly recommend that when you look at clinical integration, you should be leveraging the clinical application APIs. Don't go off in these kind of proprietary one-off worlds. Even HL7, although a well-standardized set of protocols, the fact is HL7 wasn't built with identity in mind. So leveraging the APIs from Epic in this case is super important. Up until a year ago, they only exposed EMP. Just within the last year, they've started to expose SCR, and most of the identity solution providers like SailPoint are building automation around both the EMP and SCR API. I'm not going to get into a technical chat right now, but the fact is there are some pros and cons to both APIs. There's things you can do really well, and there's some limitations, especially on the SCR side. So as you think about how much you want to automate, you definitely need to peel back those APIs, understand the benefits of them, understand where there are some gaps, and what you can do to get around those gaps. But maybe Scott and Andrew, can you talk about any type of automation you built specifically around Epic?
Yeah, I mean, I can touch on what we've done, and sort of I think I alluded to it when I talked a little bit about our process around the EMP record, which is that it is semi-automated at the moment. So it's not fully automated, but certainly there is quite a bit of automation, and we're continuing to build that further as we go forward. The SCR one is interesting, sort of as Matthew indicated. Apologies for that. As Matthew indicated, this is a relatively recent capability that Epic has allowed, and they've historically been quite proprietary with allowing external systems to be able to manage any internal Epic data. And in fact, even the EMP stuff was a difficult conversation when we started very early on. So we have not implemented any automation around our SER records at this point. It's something that we're intending to investigate so that we can begin to understand, to Matthew's point, like what are the nuances of the integration? How would that fit into our existing business processes and workflows around creating and managing those SER records? SER records inherently are, at least for us, quite messy historically, and we've actually gone through some fairly significant effort to just simply clean up the SER records, because when we went live with Epic, I can tell you it was not clean in any way. So there's a lot to consider there, is really to make sure that you fully understand that, not only because, you know, SCR is a somewhat complicated data set, because in the case of SickKids at least, it's not a record that's solely associated with our internal users. We have SCR records that created for external users who are sending in referrals to us through an integration we have with the Electronic Children's Health Network, the ECHN. So those SER records are being created for, you know, SickKids staff and physicians. It's being created for referring physicians, but it's also something that we need to use in order to be able to send information out to community physicians or the primary care physician for a particular patient. So the database includes many, many, many more records than you would have for your internal users, over whom is the primary domain that we apply identity management. So we don't really apply the same type of processes to external users. And so the SCR, the benefit of automating SCR is there's certainly some opportunities for process improvement, opportunities for automation, but it doesn't completely remove the SCR management, because there's an awful lot in that system, in that database, beyond those people over whom I have the visibility within my identity management system. So,
yeah. So in our case, just like you were saying, Scott, we had a committee that really went in and looked at the EMP and what attributes that they needed to have within Epic. And you know, there's a lot of fields in that EMP record, and some that they replicate, because as Epic added modules, they basically bolted modules on, and you replicated data so that you could get it into the module that you wanted. So we have that to do. And again, we're doing the same thing. We're looking towards SailPoint when the availability of the SCR is truly there, to start looking at bringing out that, because we didn't want to build a secondhand one. We didn't, you know, there were other companies that said, oh, we can build these for you. And I said, well, I don't want to manage a secondary source for the SCR to be brought in. I'd rather have it flow through my normal processes. So through the IDM system directly. And so we haven't tackled that. There's a separate security group that just manages SCR.
Yeah.
Right. Well, thank you, Gabrielle, for that question. I have another one for the panel. Typically, there isn't a system of record for non-payroll users and contractors. How have you dealt with that in your deployment?
You know, I say that kind of goes to my comment around sort of different authoritative sources, and that is one of our, you know, one of our additional 6 authoritative sources. So we have, you know, effectively our PeopleSoft, which is our primary HR source that includes data about our paid people. We've begun doing some work to include some unpaid populations in there, such as students, but not all students. So students within the clinical context we have in PeopleSoft, students within a research context are in yet another authoritative source, which our research organization manages. We've got our non-payroll database, which amazingly enough in 2022 is a Lotus Notes database that contains within it, you know, a number of different types of unpaid users. So it incorporated physicians, observers, and a variety of sort of contractor roles that might be short-term or long-term. And so, you know, the way we handle that at the moment is suboptimally, to be quite honest, but we've effectively created some mechanisms behind the scenes to be able to pull data in from each of those systems and, you know, mash it together in a way that allows us to feel reasonably confident that we have a record that is unique, that's individual, and that is correct. And then use that to form sort of the underlying identity to be able to run the processes against. But it is, as I said, suboptimal at best, and is one of the big focuses of that parallel process that I mentioned, to figure out how do we take these different sets of data from various systems and clean them up and be able to move them. You know, our Lotus Notes database, for example, is, you know, to pick a simplified example is department. The department name is just a free text entry. So the department admin who's onboarding a person simply types in the department name, which obviously from a master data management is not optimal, because if there's spelling mistakes, if you're, you know, writing DEPT period versus department, or, you know, concatenating different things, creating acronyms. I mean, there's a whole host of ways that you can effectively say the same department, but in about 12 different ways. And it creates a lot of challenges from a data management perspective. So that's something that we're working on, as I said, to try and figure out how do we take these, you know, poorly managed data sets, clean them up such that they actually match our data model that we've built. And then looking at the data model that we built, how do we then fill in the gaps that may not exist for certain data sets? We have a lot more information about our paid employees than we do about our unpaid employees. So how do we make sure we capture those other data elements that we need to create a complete record that we can then store hopefully in a single authoritative source?
Yeah. So I guess we're on a different part of the continuum, as most of so we have affiliate we have agencies, affiliates, students, and each one of those organizations, our HR department our HR department for non-employees, because we have a separate group for that, have negotiated out data entry into our HR system for each one of those groups. So they manage directly into our HR system, or provide downloads into it for each one of those, so that we all have our volunteers, contractors, even our affiliates, because we use an external credentialing system that pushes right into our HR system for when the person's credentialed. So they're all falling into that one repository. Now, granted, I'll agree with Scott, it's not all that great data. Sometimes it's off. And the HRSS group has to go in and help clean that up. But that's, you know, we resolved the 6 or 7 different and forced them into one. And being that we're the largest hospital system in New York City, they were, you know, they were over time. Now, mind you, negotiations keep going on. So, but we've negotiated a good entry point so that they can provide us the data. But that is one of the biggest things.
Rosa, we've got another question, and since Andrew's talking, if memory serves me correct, he might have a pretty interesting story on this. But the question has to do with COVID-19, and did this create opportunities to improve your identity management program? What I can say for sure is it definitely put a spotlight on identity and cloud transformation. But Andrew, I believe you, right, firsthand saw the benefits of the investments you've made in identity over the years, especially during COVID with the transferring and onboarding of staff. Can you maybe talk a little bit about that and how COVID kind of put a spotlight on your identity program and the value of it?
Most definitely. So between March 2020 and May 2020, let's just say about 12 weeks, we onboarded about 12,000 people to help support the hospital systems. If you saw the New York news at any point, we had Jacob Javits, we had the Brooklyn Navy Yard location, we had several locations where we had to fill people in, and we got them from from our military medical staff, and we had to onboard all those people. We were able to onboard all those people. They did bulk downloads into our HR system, and then it just flew right through the identity system. Just like a normal everyday, it was just more volume, but we didn't hear a hiccup. We were able to maintain that flow of people coming in, and they all got on to the system within the timeframes of hours instead of days.
And Andrew, a key part of the question is you're still able to be aligned to your security policies and HIPAA policies.
Absolutely, yeah. They still had to go. We still had to make sure that HIPAA training was done. All those things before they got Epic access, and that was all taken care of, and the flow just kept on going. Of course, we also had to offboard 12 to 15,000 people too as it went down. We're back to enrolling some of our military because we've just gotten some military back at our Coney Island site and our North Central Bronx site for getting some relief for those people. But it was amazing that we didn't feel it, which was the good part. And it's shown to the management that this influx didn't cause them the great headache that they thought it would.
Sure, so very timely, and I can imagine what it would have been like to have to process all those entries manually for the nurses.
Well, it would have been impossible to do that manually. Is the short answer.
So bringing an army to do that, right?
Right.
Yeah, interesting. That was a good question there, Gabrielle. So I have another question. Like, both of you are very experienced in your identity programs. You've been running them for years now. What are those lessons learned and critical success factors that you can share with the audience for those that are embarking on a program or just starting a program? What would you say are the biggest lessons learned that would benefit others? And what would you say are the things that are absolutely essential in order to see the success of a program as complex as your IAM program?
I'll answer other than data, which I think I've already made my opinion on that quite clear. But I do think that there's some organizational change management that comes into play when you embark on these types of things. You have, legacy and history and staff who've been doing things a certain way for a very long time. And in many cases, you're asking them to do things in a different way. So the approach that we really took as we began this project 4 years ago or so, was we really worked hard to try and engage our user community. And in our case, that's not the individual end users, but for the most part, it's the department administrative users that are sort of managing access on behalf of the department they support. So we worked really hard with them to, obviously talk about what it is that we wanted to do, with our Epic implementation. really walk through what the processes were going to look like, help to educate them about what their roles and responsibilities would be, ensure that they understood how they could get help, ensure that we were taking that feedback and incorporating it into the process design. Then this all happened long before we ever turned anything into a technical solution, but really just understanding how is the onboarding of a user going to flow through all the various departments that are involved. And so I think that direct engagement and that really that listening to what people are having to say about what they think may work and what may not work is really critical. Now, in not all cases are you going to say, well, I'm going to make changes to support this particular departmental workflow, because the advantage of this is we have the same workflow for everybody, regardless of what their historical workflows look like. But we really took the time to make sure that we took everybody through what we were doing, why we were doing it, how we thought they were going to see benefit from it, and making sure that that communication was very robust at the time we were moving this forward. Because at the end of the day, they're the ones that are going to feel the pain or the benefit the most. And so we wanted to make sure that that feedback was really carefully incorporated in everything we did. And I think we really found through that we had, a number of our administrative users that became champions of the project, and that ultimately allowed us to, begin to move forward with building out these workflows. And it hasn't been without its hiccups. There's no doubt. We've had, learnings that we've had over the time, some of them, very granular and specific, and some of them sort of, surprising and having to be handled in real time. But the challenges around, our normal onboarding process is relatively smooth and seamless. But, when we have a large influx of residents and fellows, twice a year, the first time that happened, our workflows didn't handle it very well. So we had to make sure that we took that feedback, we learned from it, we evolved that process to ensure that, as we move forward, those predictable known influxes of people periodically through the year, we now incorporate that into our processes. Now, we've never had to bring in 12,000 people, as Andrew has. Our challenges have been slightly different and on a smaller scale to some degree. But there's always hiccups as you move these things forward. And as you identify those, as you learn what works and what doesn't work, making sure to bring together all of the different groups that are involved and make sure that you fully understand the challenges and that you address those as best as possible. But as importantly, making sure you're telling people how you're addressing them and why, to make sure that they're engaged in the conversation about these processes and how it's going to work. Is it the engagement of your user base and the engagement of those people that are ultimately responsible for managing this user within a department? You need their support, otherwise it becomes incrementally more challenging.
And I'm going to key off something Scott just said, because I think it's the key to all of this, is that you define your processes and you don't deviate as much as you don't deviate from those processes, because that's the key to its success from implementing an automated process, is that everybody is doing it the same way. Yeah. So we can get that flow in. And if we didn't do that, we wouldn't have been successful.
Yeah, it's very easy sometimes to look at technology as being the solution to the problem, that if I buy this tool and I put it in place, that's going to solve everything. But yeah, if you're not thinking through the whys and the hows before you look at technology, it's going to be so much harder. Really thinking through what does the process need to look like, and then map that process back to the technology to say, how does technology support the process that I need to run? And if you approach it from that direction, it becomes that much smoother to be able to get it into place. And recognizing that more often than not as well, these are not big bang deployments. This is typically something that you get in, you define some set of processes, a manageable set of processes, or some of the more critical processes, get those in, get them working, reap the benefits of it, demonstrate the success of the program, and then build upon it. And that's really the approach that we've taken. We continue to grow our identity program year over year for the last 3.5 years as we add more systems, we add new capabilities, we identify new use cases that may require some changes in the way some of the workflows work. So it's an evolution, and really starting with that core critical set of processes, defining the processes well, and then allowing the processes to determine the technical capabilities necessary for automation is really the best way to ensure that you're getting the fastest value and the best value out of these kind of capabilities.
I really love this, because I'm going to put my operational risk hat on, and I'm going to repeat. For those of you that know me, you've probably heard this before. Consistent, repeatable processes are operationally efficient and mitigate risk. You can't underestimate the value of good processes with an identity and access management program. They're just foundational. When we look at the capabilities of the technologies, that it's super. They automate things, but in essence, all they're doing is automating your processes. So if you don't have good processes to start with, you're not doing the organization a service by deploying the technology. So yeah, well said, Andrew and Scott, on that. Is there anything more, Matthew, is there anything you'd like to add from what you've seen?
Well, look, I was sitting here smiling for a couple of reasons. I mean, all too often I hear healthcare organizations talk about, well, you know, when we go live, you know, I can just let it go off and run itself and wipe my hands. And it's not the case, right? This is a dynamic, living, breathing solution that is truly a program. And you have to treat it as a program. And I love Scott's description of these, what I'll call small sprints, right? What are these small digestible sprints focused maybe on an initial application or initial couple business processes? Make them successful, get the story back out of that so you can go back to your C-level team and say, hey, look at the value we just delivered, and then identify the next incremental opportunity for new value. That is really key to success. It shows that you're delivering value to the organization. And by the way, back to that COVID question, the reality is with remote workforce strategies, a lot of moving staff, transferring, onboarding of temporary staff, this has really put a spotlight on cloud transformation, but also security frameworks. If you are not already aligning with the security team that, hey, we're going after high trust or NIST or some kind of security framework, you know, under NIST, there's 405D, which aligns specifically to healthcare organizations, right? And some of the security controls within healthcare. Think about how identity can help accelerate the alignment to any security framework you're pursuing, and that will speak volumes to a CIO because they are tasked with finding ways of, one, keeping bad guys out, but two, minimizing cybersecurity insurance premiums, right? And when you align to that kind of framework, which identity is a key pillar of, you can achieve that in a much faster way. So think about attaching identity to those cyber framework strategies.
That's why I'm so fortunate here that as the CISO, this falls underneath me. So I have direct control over our identity processes and the team that supports them. So we ensure that we've got great alignment between, you know, our core security operations and all the identity work we're doing.
Yeah, you're doubly motivated.
Yes.
and one thing I just want to key on this. You said about processes. There's that other side of the coin that really helps in that it's the governance side and verifying that everybody has the right things that they have on a periodic basis, which is, which, you know, the IDM we use does that. And we were fortunate this year. We implemented several, including privileged access in Epic. And the audit came back with no comments. So to me, that was the biggest success.
Fantastic. That's great. Outstanding results. There's one thing I'd like to add, and I think that I've seen this in a lot of client engagements that we've had, is when you have good executive sponsorship for a program like this, things are so much smoother. And Scott, do you want to talk about the executive? Because I think you've had a lot of good support from the CIO, and I've seen that in action, because the identity management program is a journey, and there's going to be ups and downs along the way, and having an executive sponsor can make a big difference.
Yeah, no doubt. And it, you know, goes back to maybe the very initial comment that we had, or the question we had about, you know, ensuring, you know, how did you get funding for this? And I think that's, you know, something I've been very fortunate to have here, but something I encourage a lot more dialogue about is, you know, that this isn't a decision that happens, you know, at a low level of the organization. These are transformational implementations. And so it's really critical to ensure that you have executive involvement in understanding both the why and the hows of it. And that includes the CIO, which was obviously, our primary sponsor for this, in addition to myself. But beyond the CIO, in a healthcare scenario, looking to your clinical leadership as well, to help them to understand why this is something that's critical for us to deliver, as part of our entire organizational strategy around security. And we were able to do that. We were able to work very closely with our executive team, with the CIO, with our security team, our identity team, and all of the different business units that were being impacted, and really ensure that we had alignment, but also an understanding that this was an important project, that this was transformational, that this was going to allow us to achieve a variety of benefits, not least of which is the ability to, simplify process, centralize process, which at the end of the day actually pulls many, many hours out of people's otherwise very busy days, because they no longer have to do things manually. They can rely at least on part of the automation. So you get more value out of an FTE than you would have before. So you get that operational benefit where you can redirect hours in a person's day to something that is more clinically significant than determining how and to what extent somebody gets access to a system. So very key for sure.
Thank you for that, Scott. And I'd like to thank Andrew and Matt as well for participating in this really enlightening dialogue. I've learned a lot. I hope you, as our audience and participants, have learned a lot as well. Thank you for the questions. And we're going to make this available to everyone that wants to review the video. We'll be sending it out. I just want to mention, for anybody who is based in Ontario, KeyData Associates has a contract with Plexus. It's an open contract where you can go in and request services and software for your identity management program without having to issue an RFP. If you want to learn more about that, just reach out to Sophie or myself, and we'd be happy to share further information on that. Thank you all for participating, and I hope you have a great rest of the day.